So let me take a step back with the foundational thing of the concept of mitochondrial dysfunction, uncoupling the electron transport chain, I think is the terminology used in your book, as a cause. Like one of the things I try to wrap my brain around in 1900, the average 1 in 100 Americans got cancer. And in 1990, it was 1 in 3. Now it's 1 in 2. If you had the BRCA gene in
Mm,
1950, your risk for breast cancer was about 20%. Now it's 80%.
mm,
So even with our limited knowledge, we see with the genes, massive increases in cancer rates. My question to you is, with mitochondrial inefficiency, dysfunction being part of this cancer thing, does it make sense that things that disrupt the mitochondria, environmental toxins, chemicals, foods, blah, 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 might be part of the reason why we're seeing an increased incidence of cancers in modern times that are unparalleled in history? And if so, what are your thoughts about that?
yeah, well, that's it's called the Great Western Diet and Lifestyle. Our Aboriginal ancestors did not have Dunkin' Donuts on every corner. They did not have the kinds of foods that we're eating. They didn't. They had a lot more exercise. Now, Albert Schweitzer, the great humanitarian physician, studied these tribes of people on our planet and looked at cancer was extremely rare in people who lived according to their traditional ways.
Hmm.
We call it the Paleolithic kind of a. Don't forget, as a human, we've been a species for about 1.5 million years. Most of that time was in a Paleolithic state of fasting and tremendous exercise. Okay, what killed those folks was infections and injuries. Okay, they weren't dying from cancer and these kinds of things. People say, well, they didn't live long. Well, even if they lived long, they weren't dying from cancer. Cancer emerges with our technology, and our food science and technology has advanced so much faster than has our biology. We're still basically physiologically a Paleolithic organism, driven on eating anything that walks, crawls, swims, or flies on the planet, and a lot of exercise. Today, we're sitting in traffic jams. We're sitting in front of computers, getting all freaked out by which, creating a lot of anxiety, emotional stress, bad food, food that's highly processed. In other words, we evolved to store energy. That was our goal, because if we didn't store energy in the form of fat, we would not survive as a species. So energy storage became part of our evolutionary biology. We have energy. That kind of energy is every night on TV, every corner of the grocery, Dunkin' Donuts, you can name it. It's all over the place. We're getting fat, and that's exactly evolution in action. People say, I don't understand biological evolution. Well, you understand the obesity epidemic, right? Oh, yeah, I can just see all that all over the place. That's evolution in action. That's our evolutionary past telling us that we're in a new environment now. And that environment is putting us at risk for cancer, cardiovascular disease, dementia, all of the different chronic diseases as the result of our energy balance changing. Yes, mitochondria becoming damaged. Why? Because they're being overwhelmed by a large amount of fuel that's creating reactive oxygen species and this causing a level of dysfunction. And and you're right, intermittent fasting, these kinds of things brings the body back into a more energy homeostatic state. But it's very hard for people to do water only fasting. But now we're realizing it's not if you, and that's why we developed at Boston College the glucose ketone index calculator,
Hmm.
which lets people know quantitatively whether they're in nutritional ketosis, similar to the way our ancestors were in the Paleolithic period, where injury and infections were. Now we have very great hospitals, and we can fix a lot of broken hips and knees and all this kind of stuff. And we have a lot of antibiotics, and we have a lot of ways to manage infections and injury. But our diet and lifestyle is putting us at risk for chronic diseases like cancer and cardiovascular disease and these kinds of things. So to manage that, you have to keep your mitochondria healthy. And you cannot get, it's very hard to get cancer if your mitochondria remain healthy. How do you allow mitochondria to remain healthy? You have to have them burn ketones. Ketone bodies are breakdown products of fat. When you mobilize fat, goes to the liver. Liver makes water-soluble ketone bodies. Our brains burn ketone bodies. Our muscle, heart can burn ketone bodies. Our cells get super healthy when you're burning ketone bodies. Cancer cells can't burn ketone bodies. So, yeah, so the whole concept of managing cancer as a metabolic disease is bringing the body back into a Paleolithic state and then starving tumor cells of their fermentable fuels. And you're absolutely right. You can manage many different diseases using the same strategy. The problem is not easy. Okay, let's
Correct.
be honest. Every night on TV, we're blistered by commercials telling us how good the pizza tastes, how good the donut tastes. All the sweet drinks, Coca-Cola, Pepsi Cola. I don't know. You can go up and down, name them all. Not that these are bad in small amounts. They're probably good and very tasty and all this kind of stuff. But if you do it all the time, you get obese. You don't have exercise. You have a lot of stress. No friend, all this kind of stuff. Bad sleep, apnea, all kinds of stuff. You put yourself at risk for all these chronic diseases. But that's prevention. Okay, most people. Let's be honest. We have an obesity epidemic. If people really were concerned about what I'm talking about, what you're talking about, we didn't have this kind of. That's the. So people say, okay, now I have cancer. What are you going to do for me now? We're going to poison and irradiate you, or are we going to bring you back into a new state of health and slowly degrade your tumor? That's the question you have before us now.
So a couple things you said that I want to just clarify just for the audience, because you said a whole lot. So you mentioned reactive oxygen species being made, which basically is a way of saying inflammation. So if I was to understand you correctly, inflammation by itself, however it occurs, whether it's high sugar consumption or processed foods or toxic fats, but that inflammation can lead to this mitochondrial dysfunction, which can lead to cancer. Correct? So inflammation, things that lead to inflammation, whether it's stress, not sleeping, sleep
Yeah.
apnea.
So let's look at that. It's called chronic inflammation. And you can measure that by C-reactive protein. Just do blood work. People can, when I go to the physician, I don't know, once a year, twice a year, whatever it is, I tell them exactly what they should be looking at. I don't allow them to tell me. I tell them, here are all my ferritins. I have my vitamin Ds. I have all PSA, test A, H1C, all the different things. So I know how my body is doing on that day that they took that blood work. And I monitor those things over time. Triglycerides, HDL, all the different things that one could look at. You put it together and you look at, and the blood work tells you whether or not you're in metabolic homeostasis.
Yep.
So it's not hard to do. So everybody can do this. But you're right. Chronic inflammation creates damage. Reactive oxygens, ROS. This is the reactive anion and the oxygen and this kind of thing. They are carcinogenic and mutagenic. So they damage mitochondrial function. And they also cause the mutations in the nucleus. So a lot of the cancer cells have bad mitochondria, throwing out reactive oxygen species, which are carcinogenic and mutagenic, causing the chromosomal and genetic abnormalities that you see in the nucleus. So that's why we know all the genetic stuff is downstream. It's the energy metabolism that's the ultimate cause of dysregulated cell growth. So yes, chronic inflammation is one. Viral infections. They have oncogenic viruses like hepatitis papilloma. They've damaged mitochondria. Carcinogen. What do you call something a carcinogen? It's a chemical that causes cancer. How does it cause cancer? It actually damages oxidative phosphorylation, creating oxygen radicals, leading to a fermentation metabolism, right? Sleep apnea, intermittent hypoxia. I noticed that, when I was going to one of these dental meetings, I was watching these films of people sleeping who had sleep apnea. I said, oh my God, this guy hasn't taken a breath in 35 seconds. And then all of a sudden the body, he has, Warburg clearly said, intermittent hypoxia damages oxidative phosphorylation, leading to cancer. So, we see it every day, what's causing it. And we just go through the list. Radiation, people, when the Fukushima plant over in Japan went out, people in Seattle were digging foxholes or bomb shelters to protect them from the radiation coming from the plant across the ocean. Why? Oh, because radiation causes cancer. Why? Because it damages oxidative phosphorylation, leading to dysregulated cell growth. Oh, okay. So you can put all this together, and you're 100% right. Every one of these things that we've looked at that damages oxidative phosphorylation chronically can put
Yeah.
someone at risk for mitochondrial damage, which may present itself in the form of cancer or some other chronic
Yeah.
disorder. Not complicated.
Yeah. I remember reading an article about this, the concept of the genes, a couple of years ago, and I was talking about, like a typical breast cancer. There's up to 80 different genetic mutations. There's probably 80 different kinds of breast cancer, and we focus on, BRCA1, BRCA2, HER2 positive, HER2 negative, PR positive, all these small things, but literally just breast cancer by itself, there's probably 80 different genetic plus perturbations of that. And reading that, I was like, wait a second. So that makes me think it's really not ultimately a primarily genetic thing for this one disease. If 80 different plus mutations are associated, what could be under the hood? And it
Mm.
sounds like what you're saying is what's under the hood is mitochondrial, electron transport chain uncoupling,
Yeah,
resulting, which you haven't used this phrase yet, but I think it was in your book, genetic instability.
yeah,
Genetic instability gives you mutations, and over time, you eventually get one of these things that makes the cells grow
yeah.
without
Well,
control.
no, you're absolutely right. But it's the ROS reactive oxygen species that are ultimately causing the genetic instability and all the things. But Warburg said it, and we all know there's two things to get cancer. Number one, you have to damage oxidative phosphorylation chronically, not acutely, because the cell will die. Number two, that cell. Listen to this, very important. That cell must have the capacity intrinsically to upregulate the fermentation metabolism. Because if the cell cannot replace energy from oxidative phosphorylation with energy from fermentation, it won't become a cancer cell. So there are a couple of cells in our body where cancer is extremely rare, mainly because they can't upregulate fermentation chronically, and that's cardiac myocytes. So you rarely see cancers in cardiac myocytes, and neurons of the brain. The neurons can't switch chronically to fermentation. They can do it acutely if you have an epileptic seizure or you have cardiac, if you have a heart attack where everything turns, it becomes ferment. The whole body ferments
Yeah.
for a short period of time, but it cannot readily adapt to a fermentation. So you have to have, but cells that can gradually upregulate fermentation chronically, like liver, kidney, bladder, breast, like you said. Yes, there's hundreds of millions of mutations in breast. Every breast cancer cell is fermenting, regardless of what its genetic composition is. That's the underlying common pathophysiological problem of all cancers: brain, colon, breast. That's why I'm saying cancer is one singular type of disease of energy metabolism. The mutations are all different, but the underlying problem is the same. They are fermenters
Interesting.
depending on a fermentation metabolism, regardless of what their genetic composition is. So we know that. Now, when you switch from efficient oxidative phosphorylation to inefficient oxidative phosphorylation, you have to change the parameters of the cell. So this is oncogenes. People love to talk about oncogenes. Like HIF1 alpha, MYC, and these different kinds of terminologies they use for these. These are facilitators of opening the floodgates on the cell to get in the fermentable fuels. Because if you're switching from an efficient system to an inefficient system, you have to have a large stockpile of fuel to make up for the efficiency. Now you're inefficient. So floodgates for glucose and glutamine open up on the surface of the cell to bring in these two fuels. Glutamine is already the most abundant fuel in our body, and the glucose is already in our diet. So the glucose from the diet and the glutamine from the blood pouring in, driven oncogenes opening up the transporters on the surface of the cell, and the exhaust system. So they blow out lactic acid and succinic acid as waste products, and we see that. And that's why we know all the cancer cells are fermenting on glucose and glutamine, because they're all blowing out lactic acid and succinic acid. Clear as the day. It's just so clear what these cancer cells are doing, and
So,
how they're living.
so two quick questions in regards to that. First question is, I'm really big into fatty acids. Part of what I do with people with mitochondrial issues and neurological issues is work on re-regulating their fatty acid synthesis. Um, but our food system is filled mainly with processed rancid fatty acids, long chain fatty acids, trans fats. In your understanding, because it makes sense to me, but I'm just kind of curious, in your understanding, does it make sense if we're consuming these dysfunctional lipids that make up the cell membranes of the mitochondria and affect mitochondrial function, the infiltration of our dietary system with these dysfunctional fats could be a precursor for reactive oxygen species increasing and ultimately lead to an increased risk for cancer. Does that make
Yeah,
metabolic
it
sense?
could it could do that. Again, most cancer cells synthesize their own fatty acids, and most of them are saturated fatty acids.
Okay.
They use glucose. We've tested all that. We published a couple of big papers on this. I mean, the glucose carbons make the cancer cells make a lot of fat. They synthesize their own fat. So they make that. They can, yeah, you can take it up from the environment, but the bottom line is, in order to grow, you have to synthesize fatty acids, proteins, and nucleic acids. These are the building blocks of cells. You have fatty acids in the membranes. You have proteins, which are amino acids. So you need carbon and nitrogen to build all these things, right? For a cancer cell to grow, you have to. It synthesizes. Now, what it can't synthesize, it also sucks up stuff from the microenvironment. So bad fatty acids from the diet could, in fact, contribute. They're not contributing to energy, but they could damage further the mitochondria for sure. So, but the cancer cell is also synthesizing a tremendous amount of these things from its own ability to synthesize, as long as it has the energy number one, and metabolites number two. So glucose and glutamine provide both the energy and the metabolites for these cancer cells to continue to grow out of control. So, and that's why I said, if you take away the two fuels, giving them both energy and metabolites, they ain't going to grow very well. So that's the strategy. And yeah, I think that the consumption of provocative fatty acids and other things as well, that could damage oxidative phosphorylation, may contribute to the gradual degradation of the ability of the cell to generate efficient energy through oxidative phosphorylation. It's a little bit more complicated, and there's a lot of factors that I'm not going to address.
Yeah.
But it's our goal is we got a person with a cancer. Let's get rid of it. And how do we do that? And we can do that. Then after we do that, I think we can start focusing on all other issues that may
Yeah.
not be as acutely important as keeping somebody alive.
Yeah. And just another side question, real quick, from what you said. Can you use LDH, lactate dehydrogenase, as a surrogate marker for lactic acid, increased production of lactic acid?
Depends whether it's LDHA or LDHB. LDHA brings in ketone bodies and lactate into cells. I'm sorry, LDHB. LDHA is the exhaust. So when you create a tremendous amount of lactic acid in the cell, LDHA, there's actually 5 different forms
Yeah.
of lactic acid dehydrogenase, but it's LDHA is the one that's upregulated massively. So it's part of it run by HIF1 alpha, the oncogene. So what happens when oxygen is deprived? Glycolysis is upregulated tremendously, and lactic acid is dumped out, and you have to upregulate the activity of LDHA, lactic acid dehydrogenase A. So most aggressive cancers have very high LDHA, and that's controlled by HIF1 alpha, a transcription factor, which is one of the oncogenes that we talked about.
Okay.
So yeah, most cancers, but people, there's a lot of work going on. Oh, let's target LDHA. Why target LDHA? Just have to pull the plug on the glucose. If the glucose goes down, it damns the glycolytic pathway is downregulated, and the amount of lactic acid coming out is downregulated, and the cell can't get energy and dies. So this is why it's so incredibly simple to do this. People are always wondering something. They always want to go to some level of complexity you don't have to go to, just to make it look like they know what they're talking about. The idea here is we're going to kill cancer cells, and we want to do it easy, and we want to do it quickly. You got to pull the plug on their fuels and transition to something they can't use. All other issues become secondary.
Gotcha. Well, let's make a slight transition from the science, because I feel like we could talk about the science for hours. The practicality, because ultimately people, either want to prevent cancer. I mean, 1 in 2 people in our country getting cancer is a crazy number, or they know someone who's had cancer. So I guess my first question with this little transition is, how are first of all, with your research, what kind of outcomes have you seen? Because you hear about people going to clinics in Mexico or over. I had a patient go to Germany. It sounds like you're doing research up at Boston. Could you give us some examples of patients in your research and what kind of research is going on using this modality as a way to come alongside and help people with a diagnosis of cancer?
Yeah, well, we publish papers on it and we describe what we've done. And of course, they're singular cases. Um, we're not running clinical trials only because people don't know how to do this and nobody wants to support it anyway.
Yeah.
But so you take individuals, and we have a lung cancer patient from Greece who went on a keto Mediterranean diet, got into a lower GKI with a lung cancer that metastasized to his brain. We published a paper in the journal Curas, and people can read the details of what was done by my good physician colleague Athanasios Evangelio and his staff in Greece. And then we had one out of Turkey, advanced breast cancer that metastasized to the brain. The person was lit up like a Christmas tree on PET scan. And we used a combination of keto metabolic therapy with reduced chemotherapy. So we were able to get very good outcome from that person. She's still alive. These were stage 4 cancer patients that weren't expected to live. And of course, there's Pablo Kelly with the brain glioblastoma, who's out now 10 years.
Yeah.
And he's alive. We published the paper exactly what we did. We have 5 years of his dietary glucose ketone metabolites in the blood, and we published that in the journal Frontiers in Nutrition. We did one on a dog. Actually, that's our only thing we ever cured was the dog had a mast cell on his face, and we cured him. The other guys are still alive, so I don't know if they're going to be cured or not. All I know is they're living a hell of a lot longer than they were.
Yeah.
Now, Brad and Maggie Jones are doing a big documentary, and they are forming a registry and interviewing all the folks that were stage 4 terminal cancer patients that are still alive, and everyone telling their story of what they did. So they're not published case because the field doesn't believe in all this stuff, right? Oh, they don't want it. Listen, if you had a drug, any drug that would do what metabolic therapy could do, there'd be a stampede for it. There would be no tomorrow. Oh no, it comes from a diet kind of a manipulation using off patented drugs.
Yeah.
El Cheapo drugs that are used. Oh no, we can't have that. That doesn't work. But any kind of a new patented drug, which would do what metabolic therapy would, they'd say this is the greatest thing. This would be unbelievable. Yeah. But it's not happening. So what you have to do is you have to see the people. And I published case reports. And then they say, N of 1. Oh, we can't believe it's just an N of 1. If I had a drug that did what that N of 1 did, they would be all over it because it wasn't a patentable drug or a patentable strategy. I don't want to know about it. But yet, look at the data. Look at the individual who's alive. How does he feel? What's his quality of life? That's the key thing. And like you said at the beginning, they did a big study on the 92 drugs developed from the somatic mutation theory, and they only improved overall survival by 2.5 months, spending billions and billions of dollars. And the off-target effects of these drugs were horrific. And some of the drugs cause hyperprogressive disease, where the drug will kill you faster than the cancer. We have not ever seen a situation where metabolic therapy accelerated the growth of a tumor and killed a patient faster than the tumor would. Never happens, okay? Yeah. But it happens significantly in these new cancer drugs.
And how many people have come through that and just with you alone that you worked with, how many patients have you have come through and worked with the physicians you've trained or whatnot, or your experience with that?
Well, it's a work in progress. A lot of it is doing things on the go, and don't forget when we treat. I'm not a physician. I can't treat anybody, yeah. but I write the protocols and my colleagues and I write the treatment protocols by which patients should be treated by licensed practitioners. Yeah. And we're seeing we when a patient we think we're doing too much of this, pull it off. Everybody is a different metabolic entity. You can't have one shoe fit all. You got gender differences, you got age differences, you got body weight differences, you got all kinds of differences. You have to work with each patient as a separate entity, know what they can and cannot deal with, and you bring them and use the blood work as your non-invasive imaging and blood work tell you whether you're moving in the right direction. And most importantly, how do you feel? It's a very simple question. Ask the cancer patient, how do you feel? Oh, I spent all day on the toilet. I'm vomiting. No, you don't feel good. Okay, right away, I'm telling you, this way you shouldn't have to be doing any of that. But if the guy says, "Oh, geez, I feel like $1 million. I never felt better, and my cancer's getting," okay, that tells you you're on the right path.
So what I'm hearing you say is that you're individualizing the metabolic strategy per the person, not giving them a protocol for their diagnosis that you just replicate for 100 or 200 people, but you're actually individualizing based on the patient's how they feel, response, metabolic markers, and they're getting actually a personalized intervention plan.
Yes, personalized nutrition, drug diet. It's a
Yeah,
personalized. It absolutely
that's
is.
that's a novel concept.
Yeah, yeah, right. But that's what every member of every physician should want to do. That's what we call practicing the art, as they say up here in Boston.
The odd.
Practicing the art. It makes the guy feel good because then he's not following some scripted standard of care. He's following his own intuition with markers that are telling him and the patient's telling him. So it's a very feed forward feedback
Yeah,
between the physician and the patient.
yeah,
And together they work as a team. And metabolic therapy puts a lot of burden on the shoulders of the patient. The patient's going to have to be an active participant in their healing process. They're not going to just sit there like some bystander and be nuked and poisoned. They actually have to play a major role. So, this idea of battling your cancer, when you do metabolic therapy, you are absolutely battling your cancer because you are understanding what you're doing and why you're doing what you're doing.
yeah. Now, I think one thing as well to just go back to what you said before. I have a clinical research company. I've been a principal investigator for over 70 clinical trials, and I just think people don't really realize like how clinical research works, um, where you have to have one outcome. You limit the change. You can't change things based on patients' symptoms. If people aren't compliant, they get kicked out, of the studies. So why don't you briefly touch about the actual process of doing clinical research? Because I think a lot of people just don't realize when they say something has to be double blind, placebo controlled, standard of care, it really eliminates the majority of patients. When we were intake patients to our clinical trials, most people wouldn't even get in
Yeah,
because they were too overweight or the sugar number, or their A1C was too high, or they couldn't be compliant or enough. And so we almost create this false population of patients in
yeah.
clinical trials to get outcomes on a singular intervention. And that's not really quite how the real world works. So I'd be curious if you could just like dive into that concept.
Yeah, well, I think that was put in there as a strategy to eliminate any other opportunities that might be effective. Double blind crossover, a singular approach, eliminates metabolic therapy as being
Yeah.
a strategy for doing the traditional standard trials, clinical trial. Oh, where's the clinical trial? Well, our kind of clinical trial is based on how long we can keep people alive, right? And we have in glioblastoma and many other cancers, we have what we call historic controls. All right, we know that person with a
Yeah.
glioblastoma, the probability of surviving to 5 years is about 1 or 2%.
Yeah.
It's very, very low. And we can see how beautifully the survival curves are overlapped all over the world. I went through and looked at all the survival curves, and they're all almost they almost copy, and that's because they all irradiate and poison the patients the same way. It's almost like, wow, you're taking away any possible advantage that poor patient would have. You took it away because when you irradiate the brain, you free up massive amounts of glutamine, and then you give high dose steroids, sugar, and glutamine, and then you wonder why your patients are dying.
Yeah.
It's just like nuts.
Well, I
So,
think
so you do historic controls, and you look at each person. What's the probability of me keeping that guy alive 5 years? Well, really low if you do standard of care. What if I have 50% of the people that I did metabolic therapy on who made 5 years? Oh my God, that's unbelievable. What are you doing? Well, let me tell you what we're doing. Here's the way we do it. Okay, then things begin to change because bottom line, people want to live.
yeah.
They want to be lived. And I'm telling you another thing. They're dragging these poor cancer patients into these clinical trials day in day out. Oh, we got a new clinical trial. Number one, patients should ask, how is that clinical trial going to target simultaneously my glucose and glutamine? And how is it going to make the rest of the cells in my body healthy? And if they don't have an answer for that, I wouldn't do that trial.
Yeah. Well, I think it's interesting because glioblastoma multiforme, which is like almost one of the most horrendous tumors to get diagnosed with brain cancer, um, it's almost uniformly lethal. Yet, as far as like this whole metabolic thing, the literature on that goes back 50, 60 years. I think it's one of the first cancers, if I'm correct. They actually used ketogenic metabolic like diets to actually treat with patients having these. If you make it 5 years without cancer, that's unheard
Well,
of.
that's the first one was Linda Nebling's. Actually, it was 1995. Before it went, there might have been unpublished case reports, but
Yeah.
Linda published 1995.
95. Yeah, I felt like
Uh,
I read something from before that, which it probably was unpublished, but it was in a book of talking about glio. I was
yeah,
also using ketogenic diets for kids with seizure disorders. I think I was the
yeah,
Hartmans back in the 20s and 30s.
yeah,
So this concept of using your metabolism to treat untreatable things
yeah.
is actually not old. No, sorry,
It's
it's not. Sorry, it's not new. It's quite an old. Yeah,
yeah. Wilder at the Mayo Clinic in 1921 used the ketogenic diet first to manage epilepsy. That's how I worked in the field of epilepsy at Yale University and all these. That's how I got into it,
yeah,
working on managing epileptic seizures using metabolic therapy.
yeah.
And then we jumped into the cancer thing based on what Linda Nebling had, and out of Warburg were showing. But the bottom line is that while he knew that he would water only fast the epilepsy patients and get tremendous success, but you can only do that for so long before the patient dies from starvation.
Yeah.
So he developed the ketogenic diet, which blocked epileptic seizures, and then they threw ketogenic diet for epilepsy under the bus in the mid 1930s when they developed these chemicals that could stop epileptic seizures. Then it was Jim Abrams, the movie producer, produced the movies Airplane and those kinds, when his son Charlie developed intractable seizures, and he found John Freeman at Johns Hopkins University and Millie, and they developed a keto and kept Charlie alive. And Jim said, "What the hell is going on?" And he got Meryl Streep to do the first Do No Harm movie. And then all of a sudden, ketogenic diets for epilepsy started to explode all over again. And then I came in with the cancer part of this whole thing, and because nobody had been talking about managing cancer using metabolic therapy. Warburg had it designed. Nobody was switching to metabolic therapies for managing cancer. That's what we started. We started all that. So, which is actually going to be the future clinical. That's actually going to be the future standard of care. It's just a matter of time.
Yeah.
So we're seeing how science and clinical practice and outcomes have all overlapped at one point or another during the past, and we're starting to now develop therapies based on these understandings.
So, one thing you mentioned before is like a retraining for physicians, and you mentioned putting protocols together. So, if someone, 'cause I see a lot of patients that I come alongside in their cancer journey. They want different options. They want integrative choices, whatever that term means. Um, like if a practitioner wanted to try to refer a patient, or how's that work if someone's actually like they want to try something different than chemotherapy, radiation, they want to try an integrative. How does that work for an actual patient or a provider, a doctor, if they wanted to provide this option for their patients?
Well, this is a real tricky, slippery slope, as they say, because
Yes.
if you start practicing treatments that are not dictated by the standard of care, you could be reprimanded or lose your license. And a lot of physicians fear that.
Yeah.
They do what they do because they're required to do that. And when they say, geez, I know metabolic therapy will help my patients so much. Can I do that? No. And they'll say, why? Because there's no clinical trial. Well, the clinical trials are designed not to ever
Yeah.
have you do that. So it's a very it's a very paralytic kind of a thing. But occasionally we find physicians. Now, I just understand that Arizona had passed a right to try uh, type 2, where we're beginning to see some states are starting to open up a little bit more, where physicians will not will be able to practice some of these approaches without being reprimanded in
Mm.
such a way. And I think that once we can get these kinds of things off the ground and show published clinical evidence, which I do, that this stuff works. We have a paper in review right now, a very comprehensive treatment protocol for glioblastoma. In other words, an actual how to do this.
Mm.
And when this happens, you do this, and when that happens, you switch to this, and always be aware of everything that could possibly go wrong and how to address it. So it's a very comprehensive treatment manual protocol for the physician. And once that would get out published, there's your tool. Then you go and treat the patients. You collect the data and you publish the case report. You publish the outcome. for glioblastoma. And it's you can tweak it for any cancer, be honest with you, because they're all the same. They all need fermentation. You
Gotcha.
target fermentation. So this is going to happen. The problem is we have so many obstacles in the way to prevent us from doing this. These rigid standards of
Mm.
care, superficial statements. Well, I don't believe that. What the hell, man? What part of the science? What number do you not believe? You
Yeah.
know, which pathway are you not familiar with?
Yeah.
So you don't. You have all of these superficial reasons why you can't do what you're supposed to do,
Yeah.
but it all break down because you know why people want to live.
They do. Yeah.
That's your motivation. People want to live.
Yeah. I remind people when they ask about, it's not standard of care. What's the evidence? I just remind people that, um, vitamin D per Medicare, vitamin D testing for screening is still considered experimental or controversial, and screening for an A1C for patients for prediabetes by Medicare is still considered experimental. And so, if something that as basic as vitamin D and A1C is still considered experimental by one of the biggest covers in the country, then obviously anything more complex than that is going to be even more controversial.
Yeah, well, the bottom line here is if you don't take vitamin D, you're not going to be dead in 6 months. You can live. You can just walk out in the sunshine.
Yeah,
Diabetes isn't going to kill you. You got diabetes today, and you're terminal now. No, no. When you have cancer, man, it's altogether different. You're dealing with a different beast here. It puts the fear of God into the soul when you're told that you have cancer. You want to live, and you want to do what's going to keep you alive. And if there's something out there that's legitimate and based on hard science, and it becomes scientific. One of the things I do here at Boston College teaching biology is called scientific literacy. We
mhm,
have to become scientifically literate. We are responsible for the existence of our soul on this planet. And when it comes to these kinds of things, you can learn. I wish my students, when I teach the kids in the class, they're going to get a grade on this stuff. But I'll tell you, when you have a cancer patient that needs to know this, you'd be surprised how smart they become in a very short period of time.
yeah,
I wish my students could become this smart. It's the motivation. You know why? Because
yeah,
his
no,
life is on the line. He wants to leave. He better understand scientific literacy real quick. And the
yeah,
other thing too is we don't deny anyone who would like to take a toxic poison or be surgically mutilated or irradiated. We're not stopping any of these folks from wanting to do that. That's their choice. And some people say, "Listen, I'm sorry. I love Hershey bars. I love chalupas and Big Macs and soft drinks. And I'm sorry. I prefer radiation and chemo." I say, fine. I mean, it's not my problem. That's your problem.
So, Dr. Seyfried, this is a great conversation. I've loved it. We could go on for quite some time. Um, I probably would recommend if as a practitioner, I have a lot of practitioners that follow me as well. I'd recommend for practitioners if they want to learn more to read your book, A Metabolic Approach to Cancer, which I feel like is the tome that actually dives into this. But for everybody else out there, if they want to learn more about what you're doing or these concepts, if they're still not, they're curious about what recommendation would you have, or to even follow what you're doing? Would you have any recommendations for those individuals?
Well, yeah, because we published most of the stuff I've mentioned with you today in this conversation is on open access publication, so
Okay.
everybody can read it. And don't forget, our case reports are all
Yeah.
open access. Even the dog report is open access.
Yeah.
So just put my name, Thomas Seyfried. What did he publish?
Yeah.
Okay, and you'll see publications, and then you can read open access. If you have Google or you're on the internet, you can get it.
Yeah.
And don't forget, all of our research currently is supported by philanthropy and private foundations.
Mm.
So if people want to, it's unbelievable. There are folks on this planet who just want to be part of the paradigm change. They want to feel good that they're going to do something for mankind, and they throw us some money into Travis Christofferson's foundation and to Boston College Cancer Fund.
Mm.
So people can donate directly to our research through the university, Boston College, or through Travis Christofferson's foundation and some other small foundations that support our work. So the longer we don't forget, we do everything preclinically. We have model systems that tell us what works and what doesn't work, and I immediately share that information with my clinical colleagues, who then start to test it on the patients, and their feed-forward feedback. We develop doses, timing, and scheduling, and our goal is to keep mice alive for as long as possible. just like we do in the clinic. The bottom line is how long you can keep a terminal subject alive
Yeah.
far longer than would be predicted. And boy, humans do so much better than these poor mice.
Oh, wow.
Oh my God, humans are the ultimate example of success if you really want to know it. So that's what keeps us going. And yeah, we're publishing. I got a couple of big ones right on the. We have a couple of coming down the pike here that are going to shake the foundations of the entire establishment. Where they're in the works right now. Treatment protocols, new information on the science behind what I'm saying. Tough papers written.
No.
So observation, diet drug combinations that are really spectacular. So all this stuff is going to come down, and it will filter into clinical practice, and ultimately, you're going to see people walking the planet for far longer than they ever imagined. So this is going to happen. It's just a matter of time. That's all I can
Gotcha.
say.
Dr. Seyfried, I really, really appreciate your time, taking your time away from your job just to come talk to us and share this information. Um, and it's been great time. Hopefully this information is helpful to people that are listening to give them hope, but also realize there's other things out there. And there's brilliant people working at well-established organizations. Boston College are doing great things. Um, I feel like most cool things are happening now are happening outside of the standard of care, not within the standard of care in our country.
Yeah. Well, thank you very much. It was a real pleasure, and have a nice day.
Take care.